114 of the House of Commons Standing Committee on Health. Before we begin, I'd like to remind all members and other meeting participants in the room of the following important preventative
Monsieur le
measures.
Président,
Oui, monsieur.
il faut ajuster le son là, parce que j'ai pas le son.
I'm not receiving the volume that I need. I don't want to have to raise my volume to the max to hear interpretation, so I'm wondering if interpreters can perhaps speak a little louder or raise our volume because I can't hear.
Mr. Chair, I would concur as well. I have to push this right up to my ear to hear the interpreters.
All right, I'm going to restart and perhaps have Dr. Kitchen and Mr. Theriault indicate to me whether the problem has resolved. If it hasn't, it may be necessary to suspend to deal with it. Okay. Monsieur Dr. Kitchen, est-ce que ça marche maintenant?
Are you hearing interpretation better now?
Someone to speak French so I can hear the translation, because I can hear you clearly when you're speaking English, but when Mr. Theriault is speaking and the interpretation, I could hardly hear it.
Pouvez-vous m'entendre maintenant?
This is the interpreter. Can you hear her now? Is the volume any louder?
Ce n'est pas assez fort.
The volume isn't loud enough?
Le son,
Okay.
c'est vraiment pas bon.
Okay. Ms. Goodrich?
Thank you, Mr. Chair. I don't believe that all of the microphones are working or the speakers in the room are working or turned up adequately to actually be able to hear people.
Okay, we're going to suspend to try to deal with these technical problems before we start. if the sound quality has improved. Mr. Thériault, is it better now?
Oui, c'est mieux.
Yes, it is better now. Mr. Kitchen, is it working better for you? Are you hearing interpretation?
C'est bon maintenant?
Yes.
Okay, thank you. All right, I'm going to start at the top because we barely got into it. Welcome to meeting number 114 of the House of Commons Standing Committee on Health. Before we begin, I would like to remind all members and other meeting participants in the room of the following important preventative measures to prevent disruptive and potentially harmful audio feedback incidents that cause injuries. All in-person participants are reminded to keep their earpieces away from all microphones at all times. As indicated in the communique from the Speaker to all members on Monday, April 29th, the following measures have been taken to prevent audio feedback incidents. All earpieces have been replaced by a model that greatly reduces the probability of audio feedback. The new earpieces are black in color, whereas the former earpieces were gray. Please only use a black approved earpiece. By default, all unused earpieces will be unplugged at the start of the meeting. When you are not using your earpiece, please place it face down in the middle of the sticker for this purpose that you will find on the table as indicated. Please consult the cards on the table for guidelines to prevent audio feedback incidents. The room layout has been adjusted to increase the distance between microphones and reduce any chance of feedback from ambient noise, from an ambient earpiece. These measures are in place so that we can conduct our business without interruption, without any more interruption, and to protect the health and safety of all participants, including the interpreters. Thank you for your cooperation. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on November 8, 2023, the committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. I'd like to welcome our panel of witnesses. We have with us here in the room Dr. Sharon Koivu, addiction physician, and online Dr. Bernadette Pauley, professor and scientist with the Canadian Institute for Substance Use Research, School of Nursing at the University of Victoria. Also by video conference, representing the Thunderbird Partnership Foundation, Dr. Carol Hopkins, Chief Executive Officer. And finally, as well by video conference, representing the Vuntut-Gwitchin First Nation, Chief Pauline Frost. Thank you for your patience to all of our witnesses. Thank you for being with us. Parliament Hill is a place where rumors are a constant, and I heard a rumor today that there's going to be a vote in roughly 45 minutes. If that happens, the meeting is likely to be interrupted, and we will likely be asking you to stay a little later than you might have anticipated. So if you are able to stay with us to ensure that everyone gets a chance to fully converse the matters with us, it will probably result in your time with us being extended from 5:30 until 6 o'clock or a little later. So I'll give you a heads up for that, and we can now go ahead with our opening statements, beginning with Dr. Koivu. You have the floor for the next 5 minutes. Welcome to the committee.
Thank you, Mr. Chair, members of the committee. I've been a physician for 39 years. I have my certificate of added competency in palliative care and addiction medicine from the College of Family Physicians of Canada. I began working in addiction medicine in 2012, and until 2021, I was the sole healthcare provider offering comprehensive consults in addiction medicine at London Health Sciences Centre, where in 2023, an interprofessional addiction team was established. I also provide addiction consults in St. Thomas. I decided to speak out to bring a voice to the horrific suffering I have witnessed from Safe Supply. Early in my addiction career, I identified a link between injecting long-acting hydromorphone capsules and developing a heart valve infection. An infectious disease specialist I work with found a link with injecting these capsules and getting HIV. When this specialist and the department chair took our findings to the community agencies, we were initially criticized and called fearmongers. Fortunately, we established community engagement and developed an integrated response. As part of the response, in 2016, London Intercommunity Health Centre developed a program which provided high-risk sex workers using hydromorphone capsules with short-acting hydromorphone tablets, also called Dilaudid. This was the inception of the Safe Supply program in London. I initially supported the program. It is important to note that we did not have a problem with illicit fentanyl at this time. Prior to the Safe Supply program, I rarely saw people with spine infections. In the following summer, I saw 5 patients in 1 month. The numbers continued to climb. The common thread among patients was that they were injecting Dilaudid tablets. Many told me they were buying diverted Dilaudid from Safe Supply program. Some patients were in the program. I had patients who were housed using clean equipment and only injecting Dilaudid, developing horrific infections. Spine infections cause perhaps the worst suffering I have ever seen. Not only are they unbearably painful, they can also cause paraplegia and quadriplegia. In June of 2018, I had my first patient tell me that he left his apartment to live in a tent near the pharmacy close to the Safe Supply clinic in which much diversion takes place because the Safe Supply pills were cheaper and more abundant near the source. I lived in the neighborhood and watched this encampment grow. Since Safe Supply, I've been involved in about 100 hospitalizations of patients with spine infections, currently about 1 per month. Spine infections are only a small part of the suffering that we see. About 30 patients per month are admitted with another severe infection. Of patients admitted with opioid use disorder, 25% were receiving a Safe Supply prescription and 25% reported using diverted Dilaudid. Only 4% of the consults we see were for unintentional overdose. Generally in hospital, we start patients on home medications. If we did this for Safe Supply patients, the results could be fatal. This is dangerous for patients and very stressful for healthcare providers. For example, patient 1 was prescribed Dilaudid 8 milligrams, D8s, 40 tablets per day, and long-acting morphine 100 milligrams, 9 capsules per day. When they were given less than half of their prescribed dose, they had a severe respiratory depression, that is, toxicity. Patient 2 has frequent admissions requiring intubation. They were prescribed 28 D8s per day, tolerated about 6 to 8, and said they never take more than 12 in a day. The patient population has changed. I see more young patients, many more men, and now most started opioids recreationally and not with a prescription for pain, as was the case in 2012. I am repeatedly hearing disturbing stories that people with prescriptions are vulnerable to violence. Importantly, as I mentioned previously, when Safe Supply started in 2016, we did not have a problem with illicit fentanyl. We do now. Many patients have told me they sell or trade much of their prescribed Safe Supply to buy fentanyl. Others not in the program have told me that their dealer claims to be out of Dilaudid and has sold them fentanyl, starting them down this path. Safe Supply appears to be contributing to the illicit fentanyl crisis. Safe Supply is not reducing illicit fentanyl or its harms within a community. Our hospital experience also shows that Safe Supply is preventing patients from choosing opioid agonist therapy and the opportunity for recovery. I would like to mention a program that is showing significant benefits. The Community Health Center in St. Thomas has a low-barrier approach using subcutaneous buprenorphine, also called Sublocade. They are having success serving a very similar population to London Intercommunity Health without the unintended side effects. It should be a model that we are discussing. Of note, I have broad shoulders. I found some of the comments made by Dr. Sarita on February 26th about me and cardiac surgeons to be misleading, and I do look forward to some opportunity to address this. Thank you for your work and your time. Merci, miigwech.
Thank you, Dr. Koivu. Next, Dr. Pauly, please, for 5 minutes.
Good afternoon, and thank you for the opportunity to be here. My name is Dr. Bernadette Pauly. I'm a professor in nursing at the University of Victoria and a scientist at the Canadian Institute for Substance Use Research. I'm a member of the research team conducting the BC provincial evaluation of prescribed safer supply. Prior to introduction of the prescribed safer supply policy, the evidence of need for that intervention was well demonstrated by the overdose deaths caused by the unregulated drug market. However, it's critical to generate evidence of ethically justified interventions and determine whether or not prescribed safer supply reduces overdose risk. To answer that question, our team designed a rigorous mixed method study using state-of-the-art approaches combining administrative and primary data. In January of 2024, the team led by Dr. Sloan White and senior scientist Dr. Nosik published the first ever population level study in British Medical Journal, a high impact journal. The findings were that everyone receiving risk mitigation or prescribed safer supply prescriptions, everyone was included in the study who received it and carefully matched with people not receiving it on multiple variables, including receipt of opiate agonist treatment. For those receiving opioids through this program, the risk of dying from any cause was reduced by 61%, and risk of dying of an overdose was cut in half. If they received 4 days or more, their overdose risk was further reduced to 89%. This is known as a dose-response relationship, and the finding was independent of opiate agonist treatment. A similar pattern was found for stimulants, but the sample size was smaller, so less certainty. This protective effect continues as long as people are able to, week after week, as long as they're able to access a prescription. However, only 7.6% of those with an opioid use disorder and less than 3% of those with a stimulant disorder received the intervention during the period of study. So there was limited implementation, with implementation mainly occurring in urban areas like Vancouver and Victoria, and among prescribers who had larger caseloads of people with substance use disorder and more complex problems. While the intervention did not fix all their issues, nor was it expected to, it was protective for reducing risk of overdose death and all causes of death. In a qualitative analysis, we found that prescribers were hesitant to take up the intervention out of fear of audits from regulatory colleges, as well as criticism and censure from colleagues. Where there were networks of prescribers who had support, there was increased continuity of prescribing. However, prescribing alone is an inadequate response to a systems issue, namely prohibition and an unregulated, unsafe supply of drugs. The intervention was often difficult to access. Participants in the qualitative arm of the study reported the need to climb a steep staircase with many steps. Often, potential participants did not know about the risk mitigation guidance or safer supply. When they got their hopes up, they had to find a prescriber and navigate highly medicalized systems to get an appropriate prescription and then pick it up daily to keep it. This required self-advocacy and fortitude. In a primary survey of 197 people, less than half of participants received a prescription sufficient to reduce withdrawal. Reducing withdrawal is a minimum requirement, so there's room for improvement. Prescribed safer supply is not a competitor to OAT or any form of treatment. It provides a pathway for people to access a life-saving intervention as part of individual recovery journeys. It does not replace or threaten the need for treatment. In fact, treatment options must be available for people if and when they are ready as part of a system of care. In spite of this, the number of people dispensed a prescription in BC is decreasing. Fears of diversion causing death are unfounded. Hydromorphone was detected in 3% of overdose deaths in 2023. It's unregulated fentanyl that's responsible for 85% of the toxic drug deaths. The root problem driving this emergency is toxic drugs, which is a consequence of prohibition. The unregulated market is accessed by those with substance use disorders and those without. We need to expand access to alternatives beyond the healthcare system to ensure safe and regulated access to substances of known safety, quality, and composition. We should be scaling up, not scaling back, safer alternatives to the unregulated drug market and looking to end prohibition. Thank you, and I look forward to the questions and comments.
Thank you, Dr. Pauly. Next, on behalf of the Thunderbird Partnership Foundation, Dr. Carol Hopkins. Welcome to the committee. You have the floor. I'm
Carol Hopkins of the Lenape Nation here in southwestern Ontario. I'd like to acknowledge the lands that you are joining us from, or we're all coming together today. In 2023, First Nations deaths due to drug poisoning were 36 times that of the general population in Ontario. And in 8 short years, from 2016 to 2023, First Nations death due to the toxic drug supply grew 33 times that of the Ontario population. During the pandemic from 2019 to 2022, 28% of First Nations used opioids in a harmful way. 18% used methamphetamines to survive an environment where there were no resources for housing, food security, and income security. Those that reported food security were 2 times more likely to use methamphetamine, according to a survey that Thunderbird ran. 40% of First Nations reporting methamphetamine use felt hopeless to change their lives. And it was this hopelessness that increased their risk for using opioids in a harmful way. This population also reports a high rate of trauma, grief, and loss, and with a lack of resources close to home to support their mental wellness. Fentanyl, benzodiazepines, and xylazine have been increasing across all regions of Canada, including First Nations, and are core to the opioid and a toxic drug crisis that we are talking about today. The impact of these drugs requires community-based health resources that often First Nations communities lack. First Nations communities declaring a state of emergency report no capacity for preventing deaths due to the toxic drug supply. The vulnerability, report also their vulnerability to gangs, to gun violence and murders, as well as human trafficking that is now present in many First Nations communities for the first time. The war on drugs, including the criminalization of people for their health and social needs, has been longstanding experience of First Nations people in Canada, who are only 5% of the population and yet represent 32% of those incarcerated, and Indigenous women represent 50% of the incarcerated population. The war on drugs and incarceration has not increased safety from the toxic drug supply, has not reduced crimes of survival for people who live with opioid dependency, nor has it eliminated the illicit and toxic supply. Indigenous Services Canada does not provide for physician or pharmacy services in First Nations communities. And we know that that's a responsibility of the provinces and territories. So in this context, the opioid crisis and toxic drug crisis are not just a geographical issue, meaning rural and remoteness of First Nations communities are exempt from the toxic drug supply or the opioid crisis. The crisis actually is a lack of equitable, available, and accessible health care for First Nations, such as a lack of access to primary health care, physician services, pharmacy, and to public health resources, all necessary components of a response to the toxic drug crisis. Live-in drug treatment aimed at abstinence is not the evidence-based for addressing opioids, and it is not the first line of evidence-based intervention. Abstinence-based programs will not change drug dependency or address the physical withdrawals from opioids. Where live-in treatment programs have additional resources, for example, through provincial health authorities, harm reduction networks, and First Nations governed culture-based, land-based services, and have options to readmit or keep First Nations on a continuous basis, clients have gone on to employment obtaining housing, and maintaining their own wellness. Buprenorphine treatment initiated either by the community's primary care physician when they are lucky enough to obtain a partnership, or through addictions physicians through telemedicine or fly-in locums dispensed daily under supervision, has proven effective, along with a recovery program involving community mental health workers who provide both conventional counseling and culturally relevant healing practice. This comprehensive approach has enabled many patients or First Nations people to stop or manage their opioid use with a return to work, school, and family. A year after such programs have been initiated, criminal charges and medevac transfers decreased. The needle distribution program dispensed less than half its previous volume, and rates of school attendance increased. But addressing the opioid crisis has been challenging for First Nations communities, most significantly because of inconsistent support and resources to community-governed and culturally relevant treatment. One study of community-based opioid misuse reported that among adults aged 20 to 15, 28% were on buprenorphine naloxone, double the rate of adults in the community living with type 2 diabetes. First Nations people have the right to live life. They have the right to the sacred breath of life, and that has to be our focus in any drug policies that are humane and sensible for First Nations communities. First Nations communities require increased capacity for reducing harms related to opioids, opioid analogs, methamphetamine, xylazine, such as consistent support and access to prescribers, pharmacy, safe housing, food security, medication to address withdrawal, and a choice to continue to use drugs safely. Harm reduction kits and resources are needed. Human resources
Dr.
are
Hopkins,
also needed.
Sorry to interrupt. If I could get you to wrap up, you will get a chance to expand on your presentation in questions and answers.
Thank you.
Okay.
Human resources are needed in community, and the existing resources of treatment centers can also play a role, but they need additional resources and capacity as well. Thank you.
Thank you. And last but not least, from the Vuntut Gwitchin First Nation, Chief Pauline Frost, thank you for being with us. You have the floor.
Thank you. I appreciate the opportunity today. I am the chief of a very small fly-in community.
Excuse me, Chief
Yep.
Frost. I'm sorry.
Okay.
The bells are ringing, and that means that we're obligated to go and vote unless we have unanimous consent to continue on. Do we have unanimous consent to allow Chief Frost to finish her opening statement before heading off to vote?
Monsieur le Président,
Oui.
pendant qu'on...
Chair, in the room, can we lower the volume in the room so that I can hear interpretation without having to increase volume? I find the room volume too high.
Exactement le contraire de le début.
So we're having the opposite issue than what we were having at the start of the meeting.
Ça, c'est un problème qu'on devrait...
This is something that should be solved at the start of all meetings. There should be sound tests. It's not the first time that I've had to do this, and I didn't want to interrupt the witnesses, but it can be difficult to follow interpretation.
Okay, is there anything you can do about that? Okay, Mr. Thériault, est-ce que...
Mr. Thériault, is it any better? Inaudible.
Chief Frost, sorry for the interruption. You go ahead and finish your opening statement, and we'll likely suspend once you're done. So you have 5 minutes. Go ahead.
Okay, thank you. I, as the former Minister of Health and Social Services for the Government of Yukon, I was responsible for the identifying with the opioid crises as well as the COVID pandemic. At the same time, I worked as a lead negotiator for my First Nations, a small isolated Aboriginal community in North Yukon. We signed our self-government 30-some years ago. We exercise our inherent right to self-determination. We have responsibilities for the general welfare of all citizens, our community, the land, and the resources. As an isolated community, we're resilient people, resilient in that we are connected to our roots, our traditions. At the same time, we are deeply affected by the opioid crises, the toxic drug overdoses in the Yukon and across this country. The serious challenges that we face and the high cost of living, food security is huge. Fiscal capacity is limited in our communities, causing significant challenges. Addressing mental health and substance use challenges have arisen in our history due to colonialism, racism, intergenerational trauma. All of this is a priority for my community. In April of 2023, we declared a state of emergency and substance use crises in my community. The reason for that is we've suffered significant loss due to opioid and alcohol drug use and abuse. Over the last 5 years, we've lost 15 Vantakwichan citizens linked to substance use. Now, because of the small community, it's very complex and it affects everyone, compound impacts and effects. Every person in my community has been affected in one way, shape, or form. Because we're an isolated community, our citizens are required to travel out of community for amenity support, medical supports, and therefore we tend to see impacts and effects when they do get to the city. So an urban center effect on Aboriginal Northern isolated people. We have worked tirelessly to support our citizens the best we can with healing and wellness. Our approach has been comprehensive and non-judgmental. We commit to facilitating easier access to treatment services. We set aside last year almost $1 million in supporting our citizens to access treatment programs. That comes out of our base funding that we get for programs and services from our FTA base. Ensuring consistent availability of counselors both locally and remotely is a priority for me as a chief, and we are developing aftercare programs that provide supports to our community. So what I'm saying here is we are working hard to combat the supply of substance use into our communities. We are utilizing the Yukon Safer Communities Neighborhoods Act to address and combat the drug trafficking and bootlegging. We've asked for changes to the security designation for our northern airports to implement passenger baggage and freight screening for northbound routes equivalent to southbound. So in other words, the drug traffickers can come into our community without restrictions whatsoever because we're remote fly-in. We're limited. Our tools are limited. But we are making significant headway, and we have sent over 70 people to a treatment facility in southern parts of the BC because the Yukon is not equipped. Treatment options are not available to us in the Yukon. We are limited availability. We need more. My First Nations need support to implement our programs and improve wellness of my people. As we are on the ground, we know what's happening. We have the flexibility, but we are also trying to address the crises. Adequate and secure funding for life-saving interventions is not going to save us. It's not going to help us. We need more supports in addressing the illicit overdoses and program services. We also look at a piecemeal funding program available to us through the federal government and territorial government, which is not sufficient. We just had asked last year at the Prime Minister's Forum direct access to funding and support, put it in our base and let us provide services. We don't have that flexibility. There needs to be consideration of political, social, economical, and cultural pressures that we're facing. So I want to just quickly say that we just finished a coroner's inquest in the city of Whitehorse in Yukon for 4 overdose deaths at the emergency shelter facility. 2 of those individuals were residents of my community. We also are proud of our community because we are resilient. We've done amazing. We own an airline. We don't have a housing crisis, but our people are directly affected. We have to make a meaningful difference in the services that's provided, and the only way forward is by working together, jointly addressing. We have looked at options, exchange coming into a community. We've educated our citizens. We have looked at alternative options. We are totally looking at a recovery withdrawal supports in our community. We also have to look at a distribution program. Everything we need to do is building on healthier families, healthier communities. For the first time, we are actually focusing now on our young people, and we have a youth program, a youth wellness program that we're bringing our youth together. Facilitators are coming in. Thank you. Appreciate this time.
Thank you, Chief Frost. Okay, so we're going to suspend now to allow for members to vote. You can expect the suspension to last for about a half an hour, and then probably about an hour of questions, more or less. So stretch your legs, and we'll be back to you once we've voted and returned. The meeting is now suspended. Finished with opening statements, now ready to move to rounds of questions. We're going to begin with the Conservatives for 6 minutes. Dr. Ellis.
Thank you very much, Chair, and thank you to the witnesses for their patience. Dr. Koivu, I listened carefully to your opening statement, and one of the questions that I had was, you know, when we look at the patients, a couple of whom you described, we're really not offering them any other therapy other than opioid therapy, perhaps other things in addition to it. But just for the sake of those listening at home, we all know that people who take opioids will eventually get habituated or used to the dose they're on, requiring escalating doses. And if that's the kind of medicine that we're going to provide, is it not that fair then to say that we're providing these folks with palliative care?
Mr. Chair, thank you for that question. Absolutely. That is one of the significant problems with opioids is as you take them, your brain has changes in your neurochemicals that what you're taking, your brain becomes used to, and that becomes your normal. So to get the same effect, you have to increase the dose that you're taking. So to get the same euphoria, you have to continue to increase the dose. But perhaps even more importantly, when your brain readapts to this new level of that's your normal, you have to be taking opioids. You have to be taking them. And if you miss them, then your brain will miss them, and you go into what's called withdrawal. And withdrawal is a horrific experience where you get severe pain, anxiety, nausea, vomiting, diarrhea. You can feel literally like you're going to die. And then you keep thinking you need more and you need a higher dose. So whenever you're in a scenario where you're taking an opioid regularly, you're always chasing the high. Your dose continues to escalate. And you're always trying to medicate away from the withdrawal. And an important thing that isn't always mentioned that I want to add is that as your brain regulates and gets used to a certain amount of opioids, that's generally you tolerate that if you are well. If you develop a pneumonia, an endocarditis, or any other illness that affects your cardiorespiratory system, that same dose can be toxic or fatal. So when you're taking an opioid, you could be taking the same dose. You could be taking the same dose of your Dilaudid or your fentanyl. And if you develop a pneumonia, a sepsis, you will actually could become toxic from the same dose because your brain wants more than what your body can now tolerate. So when you are in a position of getting a treatment that's given to you daily to keep you going from one chasing withdrawal to another, it's not allowing your brain an opportunity for recovery. You are staying in a cycle in which you are absolutely dependent on the medication and can be at risk of developing tolerance, needing a higher dose, and needing a dose that eventually will be more than you can handle. And from the cases that I mentioned in hospital, patients were being prescribed substantially more than they could actually tolerate when we had them in a position where we could see what they were taking. And had we given them the amount that they were prescribed, it would have been fatal for them.
Thank you very much for that, Dr. Koivu. And through you, Chair, it's interesting that you started talking about dosages. So when we looked at patient one, I wrote this down, they had 900 milligrams of morphine and 320 milligrams of hydromorphone. Using an opioid calculator to kind of look at the overall dose of milligrams of morphine, that would be about 2,500 milligram morphine equivalents. Is that correct?
That is correct.
Thank you for that. And through you, Chair, again, looking at that for the average Canadian, again, doing the math, that's about 640 Tylenol 3. You don't have to trust me on that, but I used the same calculator to do it. And the reason I talk a bit about this is people often think, well, it's one tablet of 8 milligrams of Dilaudid. And I think that it's a bit concerning that for those who don't use opioids on a regular basis, that even though it's one tablet, it is still a significant amount of opioid. And maybe, Dr. Koivu, you could talk a bit about that.
Absolutely. One tablet is also equivalent to 4 Percocet or 20 milligrams of OxyContin. Those are doses that we considered fairly high during the opioid crisis. And taking 2 of them is essentially the amount that we would be considering would be, I don't know, more like what an amount that would be considered a relatively safe amount for most people. 1 even can be considered toxic if you're not used to taking it. So when we're looking at the numbers that we're seeing, they're substantially higher than the milligrams of equivalent of morphine that I was seeing during the time when people were prescribing heavily for chronic pain. These are the highest doses I've ever seen.
And through you, Chair, very quickly, Dr. Koivu, if we talked about 2,500 milligram morphine equivalents, what would be the recommended amount, say that we would, a prescriber should really be very cautious in going over? And I realize this is a different patient population even than a usual chronic pain population, but what would be a guideline for Canadians listening out there?
The guideline is 100 milligrams of morphine equivalent per day or less.
And these people are receiving up to 2,500.
Thank you.
Or more.
Or more. Thank you.
Thank you. Okay, we're going over to the Liberals. I have, okay, Dr. Hanley is good to go. All right, Dr. Hanley, you have the floor for the next 6 minutes.
Thank you very much, and thanks to all the witnesses for being here. I'm speaking today from the traditional territory of the Kwalendon First Nation and the Tanquichan Council in Whitehorse, Yukon. Dr. Hopkins, I wanted to address probably the bulk of my questions to you. Unfortunately, Chief Frost had to leave early during our vote, but in listening, I noticed you were listening acutely to her testimony and nodding. And I wondered if I might indulge, or if you can indulge me, was there anything in particular that resonated from Chief Frost's testimony based on your knowledge and experience as a chief, in her case, as a chief of an isolated northern community?
Well, we typically assume that the issue with resources and capacity to respond to the toxic drug supply is remoteness. It's geographical. And we are not asking for or expecting hospitals to be built in every one of our community. But the Canada Health Act says universal access to health care. And its objective is accessible health care without barriers to our wellness. And I mentioned this because there's lots of Canadians that live in rural and remote communities, but we are talking specifically about First Nations people. They have a right to access health care close to home where they need it. When it's not available there, then they'll go find it someplace else, which often draws them to urban environments. In urban environments, they don't always have access to the appropriate health care they need when they have opioid dependency or methamphetamine or other stimulants or even sedatives, like I said, benzodiazepines or, the tranq drug, which is not a controlled substance, xylazine. All of them have substantial effects on people when they don't have any healthcare resources close to home. And so that isn't just because of geography. That has to do with decision making. If the Canada Health Act says universal access to healthcare, no matter where people live for every resident in Canada, then where are the policies that ensure access to physician care, prescribers, nurse practitioners, pharmacy, public health resources, harm reduction resources, where they exist for the rest of the population. Why are those not made available to Canadians, to First Nations populations, no matter where they live? Often it's referred to as a jurisdictional issue. Who's responsible? The Canada Health Act is clear. Our rights as defined in treaties, the Constitution, now the UN Declaration on the Rights of Indigenous People do not erase our rights under the Canada Health Act. And so it's a decision, a policy decision, not just because of geography.
Thank you. And if you don't mind, if I'll jump in because my time is limited, but one thing that Chief Frost referred to was having spent $1 million of base funding from the VGFN, in this case, base funding to send people out for treatment. I know I can't speak specifically to those, the number of individuals. I think she mentioned 70. But we do know that often when people go outside for treatment, they come back into a community. They are at high risk, not just for overdose, but for relapse, because the community supports the aftercare that isn't there. So in really following up on your previous point, what do you know of, or could you describe models of care that work within a small community? Maybe success stories that you know of or have seen about how care can be delivered within a community so that you have that continuity through aftercare.
Yeah, communities, no matter how big or how small, remote or isolated, who have partnerships with local health authorities, with physicians, with prescribers, nurse practitioners, who deliver services by flying into the community from time to time, or from monitoring their patients through video conferencing, where there's partnership with the chief and council, where there's direction through a band council resolution to how health services are operating through the health center. These kinds of partnerships with elders and cultural practitioners, together, it's clinical support and medication with culture-based resources that have made a difference. And I gave an example of a community in Northern Ontario where that significantly reduced the crimes, the kids going into child welfare, kids showing up in school with food in their stomachs, and houses being filled up with furniture and toys and food, and life returning to normal, because it's a whole of community approach, and because the community, through a number of partners, have the resources they need to respond to the whole of the population. It's not just the impacts on the individual who uses drugs, it's the impact on the family and the whole community.
Thank you, Dr. Henry. That's your time. Monsieur Thériault, pour 6 minutes, s'il vous plaît.
You have 6 minutes, Mr. Thériault. Thank you. Thank you to all the witnesses. Mr. Chair, I don't have any preconceived notions regarding the crisis that we're trying to understand. But when I hear different witnesses, I end up a little confused. There doesn't seem to be any scientific consensus. There seems to be a split in the scientific community. Dr. Pauly, you talked about safe supply and how it saved lives. I imagine that's the main goal. My first question is, should safe supply be temporary? And if yes, how do we assess how long it should last? Second question, why is there opposition between access to treatment through safe supply and opioid agonist therapy?
Thank you. These are two very important questions. And our team, I just want to speak for a second about the split in scientific evidence that the member referred to. And actually, there isn't a split when you look at what is considered peer-reviewed evidence or evidence that's been reviewed by multiple scientists in the field. Our team did a study where we looked at all of the evidence for safe supply. There's close to 40 of these types of peer-reviewed articles. And the evidence was overwhelmingly positive in terms of connecting people to a safer alternative, reducing overdoses, but also connecting them to healthcare and to other types of supports as needed, like housing and reconnections back to family and community. And I just kind of want to mention that evidence. And then in terms of should safe supply be temporary, this is a good question, because when it was introduced in British Columbia, it was introduced as a temporary measure. However, it became clear that we need it as part of a systems response. And I really want to emphasize this piece about a systems response. And in British Columbia, we've had some evidence early on that it's when we combine multiple interventions like take-home naloxone with opiate agonist treatment, with overdose prevention, that showed some really good results, but it wasn't enough. And so safer supply comes in as another form of intervention within a comprehensive kind of approach. And then your question about, why the opposition? I think that's I personally don't understand why safer supply is being scapegoated, because the real harms here are coming from a very toxic and unregulated drug market. That is what's killing people.
Mais comment?
But, for example, what Dr. Koivu said, how do you take her comments on safe supply?
Mm-hmm. Yeah, thank you for that. And, we, our evidence has shown it reduces overdose deaths. And there is and I'll point to kind of other studies where it has not shown to increase rates. Rates of addiction are not increasing since we reduce safer supply. The description that Dr. Kovo gave is about this kind of ever, escalating kind of need for increasing dosages. That's not what I see happening in the way that prescribers here in British Columbia are practicing. And in fact, in our study, we found that safer supply medications were often at least in the first 18 months, at a lower dose than traditional opioid agonist treatment. And, I do a lot of qualitative research, and I interview people who are receiving safer supply, and I often ask them about their goals. And I would say that frequently what they talk about is the goal of getting off safer supply. And that might include, using safer supply for a period of time, maybe transitioning to OAT. But they have a plan because they too want to live to, a full and high quality of life for that. So, those are the kinds of things, those kinds of goals are, I think, really important. And I'll just, that's some of the reality of which I see here within the work that I'm doing. Thank you.
Thank you, Dr. Pauly. Next, Mr. Johns, please, for 6 minutes.
Thank you. Thank you all for your testimony. Maybe I'll start with you, Dr. Pauly. You heard from Dr. Koivu. She raised concerns around infectious complications for people using safer supply. Is this something you found in your research, people that were injecting fentanyl and then they switch over to safer supply, or people that are starting on safer supply? Is this what you're seeing in your research as well?
I'll give you kind of a bit of I think background is that, when people are injecting from the unregulated and toxic drug market, there are additives, and my colleagues on the panel have spoken to this, and how harmful those additives in the unregulated market are, and often cause abscesses and injections. And I believe that the committee had a brief submitted to you from Dr. Gomes, who looked at administrative data for people receiving safer supply, and this was in Ontario, that the actual rate of infections went down when they went into a safer supply program because they were no longer injecting toxic substances from the unregulated market, but they would have also had a connection to healthcare, and that's a really positive outcome of safer supply types of programs. And so in British Columbia, we have more injectable formulations. So if there is a concern about injection-related infections, which may be why those are being used more in British Columbia.
Dr. Koivu, given what Dr. Pauly said, could you please submit your own research to this committee that supports your claims on infections caused by hydromorphone within 14 days? Is that the will of the committee to get support for that? Yeah? The witness agreed?
I can.
Mr. Chair?
Well, if you've asked her to provide it and she agrees to provide it, I don't think you need everyone else's opinion.
On the record. Thank you so much. In terms, I'm going to go to Ms. Hopkins, and you are co-chair on the expert task force on substance use, and the expert task force was unanimous in recommending that that we scale up safer supply, that we scale up, that we stop criminalizing people who use substances, ramp up treatment on demand, recovery, prevention, and education. And you had a wide, a really wide spectrum on the expert task force on substance use. Can you speak about maybe your disappointment about the government not following through with the recommendations, and just your experience about how important it would be to reinstate the expert task force and to implement those recommendations?
Yeah, we're talking about using evidence, and the question is about whose evidence is more credible. That's quite a common conversation when it comes to First Nations people whose worldview and culture-based evidence is typically set aside. But that does not mean that, for example, culture and safe supply are like completely incompatible. Safer supply is one more tool in the toolbox. There is no silver bullet. There is not one medication. There is not one strategy, method, or form of care that will solve the opioid crisis or the toxic drug supply. There are many, many strategies that have to be used together in combination.
I don't know if the question was heard properly, and I apologize for that. I just, in terms of like we just heard from the First Nations Leadership Council and the BC First Nations Justice Council, and they're calling for an emergency cross-governmental and multilateral strategy that ensures the safety of people who use drugs. And Dr. Sayers, a BC FNJC council member, says the toxic drug crisis needs to be treated and addressed as a public health issue, not a criminal justice issue. And yes. Chief Grant Stewart also said it's very much wrapped in the destructive impacts of colonialism, right now, how we're proceeding. Can you maybe add to your thoughts on those statements?
Yeah, I just want to emphasize the importance of safer supply, that's one tool that needs to be available to everybody. In addition to understanding the context of First Nations people, as I said earlier, we do not have community-based resources necessary to address the impacts of opioid toxicity or the toxic drug supply. We don't have services close to home where people need them when they need them. And that often leads them to, moving, traveling off reserve for periods of time. And often the crowd that they most find welcoming are crowds that are involved in selling illicit drugs. That comes back into community. And now we create a new relationship that has significant impact on families and on the whole community. For the first time ever, First Nations communities are reporting murders in their community, not by First Nations people murdering First Nations people. It's by gangs coming from large urban environments onto reserve and committing these crimes. Gun violence, human trafficking has increased. And if we look at, what is the perception of that? We could say, well, there are, because of racism in Canada, First Nations people will be blamed for those kinds of activities. They did this to themselves. But that's the same sentiment of people who use drugs. They should just stop. They can just decide. Why don't they choose something different when they're losing all these things? We're blaming the victim without supporting their right to health and social services. The United Nations, sorry.
Thank you, Dr. Hopkins. Ms.
I'll
Goodrich, please, for 5 minutes.
Thank you, Mr. Chair, and I want to thank all the witnesses for being with us and being patient. It's unfortunate that Chief Frost did have to leave us before we got a chance to questions. I found her testimony to be incredibly insightful. Dr. Pauly, did the study you cited look at diversion as an issue?
Yeah, thank you. That's such an important question because that is definitely an issue that is I would say, creating the most controversy. So I will speak to two ways in which, while the study didn't directly look at diversion.
Okay, so it didn't look at diversion.
No, I will explain.
Yes or no? We've got a very limited amount of time, and I asked a very short question, and the convention in this committee is that typically witnesses answer for about the same amount of time that the question took. So did diversion get looked at?
Diversion was not apparent because there was a dose-response relationship. In other words, if people got more days of the medication, there was less risk of overdose, which suggests they were taking their medications, and there was a dose sensitivity relationship, higher doses, less risk.
Thank you.
So what this leads to is that people were taking their meds in many cases.
To Dr. Koivu, I'm sure you've seen the proposals that are coming out from the City of Toronto asking for a proposal to move towards a decriminalization for that city. Do you think that would have impacts on communities like London?
I think that anything that happens in Toronto is definitely going to have impact on London. And what we're seeing in London itself has been largely affected, I think, by decriminalization as it is. We're certainly seeing a lot more open drug use, a lot more, very common to see people injecting in parks and smoking fentanyl in parks and injecting Dilaudid in public spaces already. So I would think that would be something that we would have a problem with, yes.
Thank you. So really quickly, have you seen a change in the drug deaths in London since the so-called Safer Supply program came in?
Absolutely. I don't know how to answer that really quickly, but the first thing I'll say is in 2016, our overdose deaths were equal to the province. Since 2016, in 2022, where I have information, the provincial rates went up by about 2.7. London's went up by almost fourfold, so a significant increase in overdose deaths compared to the provincial average, and a significant increase in overdose deaths compared to the other community I work in, which is just south of there, which had exactly the same in 2016 and now continues to have the same as the provincial average. The other place where I see significant changes is in youth. If you look at the youth population, and this data is all available on the Public Health Ontario's opioid tool, that people 15 to 24, London's was lower than the provincial average in 2016. Now it's substantially higher, same with people 25 to 44. So when I'm looking at people that I would consider young, that there has certainly been an increase in deaths. The thing about Ontario often, also the other thing is hydromorphone is absolutely more common, over twice as common to find hydromorphone in deaths in London than the provincial average. Often the provincial averages dilute things, and if you go to Ontario, you can actually look and find that where safer supply has been available, there are increases over provincial averages.
Thank you. I appreciate that. And now I'm going to move a motion that I put on notice on Friday, Mr. Chair, and it's that the committee invite the Minister of Mental Health and Addiction and the Associate Minister of Health before the committee for no less than 2 hours, and that the study of the opioid epidemic and toxic drug crisis in Canada be extended by 6 meetings to invite further witnesses. Mr. Chair, I think it is absolutely incumbent on us, as we've been hearing testimony and seeing the entire situation shift, that we have more witnesses come so we can explore some of the public safety and other aspects that we have not been able to fully explore through this committee. I do understand that we've perhaps had some conversations about having some amendments, and with that, I will cede the conversation.
Thank you, Ms. Goodridge. The motion is in order. The debate's on the motion. Dr. Ellis has the floor.
Thank you very much, Chair, and I appreciate the comments from my colleague and the need to continue this discussion. And I think it's important for Canadians that we underline the fact that there is some controversy that exists here, not all of it based in science, much of it based in opinion, which is not necessarily helpful in an argument in where we do know there is good scientific arguments based, which many of my colleagues may not like the fact that it does exist, but it does exist. And also, I think it's important to continue on this road to enable this committee to understand that some of the science that has been referenced here does not answer the questions that we need answers to. I think it's also important that we understand that the government of British Columbia has asked for an end to the decriminalization experiment, certainly outlined by communities such as New Westminster, Richmond, Campbell River, Kamloops, Sicamous, and that as Canadians hear more and more about the experiment that has been undergoing here, Canadians are fearful for their own communities. They're fearful for their communities because of contamination from used paraphernalia. They are concerned because of the potential for exposure to drugs by children. We've heard even by pets in some areas. And the other thing that I've heard directly from Canadians is that they are concerned due to the loss of accessibility of their downtowns. And that is also a concern that we heard very clearly from the Deputy Chief of Vancouver, who testified at this committee not that long ago, who made it very clear that the decriminalization experiment has led to loss of downtowns and use of substances outside of businesses, outside of residences, on transit, near schools, parks, beaches, etc. And the Deputy Chief's testimony really related to the fact that police were powerless to stop this type of activity. So we also know that the Minister of Mental Health and Addictions has spoke very forcefully about this in the House of Commons and in the media, attempting to explain away the request by the government of British Columbia to end the experiment. And I find it interesting because it was the government of British Columbia that came to the federal government asking for the experiment, understood that. But we all know, even though this is not scientific in a sense, but when an experiment is going awry and the people in charge of the experiment say, we need to end it, then it needs to end. And when you are doing a scientific experiment, such as a randomized controlled trial, when those lead investigators understand that something has gone awry, they don't continue the experiment. They stop it. And they don't wait for days and days and days to stop it. They stop it immediately when there are those signals out there. And I'm very, very disappointed in the NDP Liberal government, and specifically in the Minister of Mental Health and Addictions, that the British Columbia government has asked for the experiment to end, and now there are negotiations with the NDP Liberal government to continue the experiment, which again, if we want to talk about this, even though I realize it's not scientific, but if we want to use that metaphor, then we know clearly that the experiment must end now for the betterment of this country. Because it's a failed experiment. We've heard that over and over and over here. We know it's a failed experiment. The BC government knows it's a failed experiment. And the question that I have is, when will the NDP Liberal government know it's a failed experiment?
Point of order from Mr. Johns.
Point of order, just for clarification, the BC government has not asked to stop decriminalization in British Columbia.
Thank you.
They have made
Mr.
Point of order.
some
Thank you very much.
changes, and I just want
point of order.
also, Mr. Chair, I think it's been well
So when my colleague,
it's been ruled
thank you
by
very
the
much, Chair. So when my colleague wants to have the floor, he can raise his hand and have his turn. He should know that. He's been here long enough, even though that he perhaps is ideologically motivated by his wacko comments. Then we need to continue on with this.
Mr. Chair?
So that being said,
point of order. Mr. Chair, it is completely unacceptable for a member to be calling another member wacko, and that is completely unacceptable. You know,
Mr. Johns, please contain yourself. He said that your comments were wacko, which may be unpleasant to hear, but it wasn't an attack on you. And your interruptions do not constitute points of order. I would ask that you wait your turn. You are on the speaker's list. You're third. Dr. Ellis, go ahead.
Thank you very much for that, Chair. And, you know, I don't mean to disparage the member. As I said, his comments are wacko. And I think it's important to understand that the citizens of this country are no longer wanting to tolerate ongoing difficulties with the experiment, as it has been termed by my friend and colleague, Dr. Handley from the Liberals, as the experiment from the outset, which was part of the motion of this study here in Health Committee. I'll end my comments there. Thank you, Chair.
Thank you, Dr. Ellis. Madame Brière, s'il vous plaît.
Merci, Monsieur le Président. D'abord.
Thank you, Mr. Chair. Dr. Ellis is mixing up the use of drugs in public spaces and decriminalization, and BC has not asked for the end of decriminalization, but rather to review their request. Considering the motion and considering that the minister has appeared before the committee, and there will be a committee of the whole at the House by the end of the month, and considering the trip that we will be doing next week, and during which we will meet people on the field and we will be able to ask them all of our questions. And so I would propose to amend the motion, and then it be read as follows: that the study on opioids and drugs be extended by 2 meetings to invite further witnesses.
An amendment. The amendment is in order. The effect of the amendment is to replace the identification of the minister and the number of meetings, to simply bring it down to 2 additional meetings to hear from witnesses. So the debate is now on the amendment, and Mr. Viss has the floor.
Well, thank you, Mr. Chair. I won't take too much time. I am a British Columbian, and it's nice to see you again. It's been a few years. I'll just I was at, the leader of the opposition mentioned the Abbotsford Soccer Association in question period today. I was at, and my son was playing on the weekend, and I asked Coach Gill, the youth coordinator for the First Kicks program, about what was taking place, and the letter itself that was featured widely in our local regional media. The decriminalization in British Columbia has led to widespread chaos. There were kids that saw a woman who was raped at our soccer field this last year, and she was on drugs when it happened. The stuff is devastating. My office is adjacent to Haven in the Hollow, which was a homeless shelter, which became a safe injection site, which during the pandemic became a place where people could openly do safe, like any drugs they wanted and consume alcohol. And it brought chaos to the neighborhood where my office is. The Legion came to me a few weeks ago, which is just less than a block away from this site. And every day they have to ask people not to consume meth and crack and other hard drugs on site. The decriminalization order put forward by the government was very clear that it wouldn't apply to those types of places, but once it was unleashed, the consequences have been grave for the residents of the Fraser Valley. I'll note in the context of decriminalization as well that in the health region where I reside, the Fraser Health region, we had, I believe last year, and don't quote me on this, but one of the highest per capita death tolls after Northern Health in British Columbia. And we, at the same time as we've had a record number of deaths, and proportionately to the rest of the population in British Columbia, the second or third highest number, there was no increase in funding to help people get clean, help people to access a detox bed, and to access a site that was going to give them the treatment they needed. So decriminalization is killing a lot of British Columbians, and I just encourage everyone to vote for this motion. I think it's a good one, and thank you for your time.
Thank you, Mr. Viss. Mr. Johns, please. Then Dr. Pelosi, with Mr. Thériault.
Well, thank you. First, I think just in terms of looking at extending the meeting, there's lots of reasons that we should have more meetings. And I look at Fort McMurray, and they have had an all-time high drug poisoning death rate just in the last year. Alberta is, their death rate has gone up from toxic drugs 17% over the last year. They're on the verge of, they're on the trajectory to pass British Columbia by June. They're at 43.3 deaths per 100,000. British Columbia is at 46.6%. It's 46.6 deaths per 100,000, sorry. Lethbridge, Mr. Chair, is triple the death rate, the toxic drug death rate of British Columbia, all without decriminalization, all without safer supply. Regina has a 43% greater death rate in terms of per capita per 100,000 than that of British Columbia. It is absolutely a tragedy what is happening in the provinces without safe supply, without decriminalization. We're seeing literally a disaster happening, a health emergency. In fact, just neighboring those provinces up in Alaska, they had a 45% increase in toxic drug deaths last year. A Republican state without safe supply, without decriminalization. So we're constantly hearing about the need to, we heard from the Police Chiefs Association that diversion of safer supply is not what's killing people. It's fentanyl. It's deadly fentanyl. We heard that from Dr. Pauly today, that 85% of deaths are from fentanyl, and only 3% of people that have died have traces of hydromorphone. The police were clear that criminalizing people who use substances causes more harm. As we heard from the expert task force, as we heard from the Police Chiefs Association, as we continue to hear from chief medical health officers, including every single chief medical health officer on Vancouver Island, who's been unequivocally clear that criminalizing people causes more harm, that safer supply reduces deaths. We have peer-reviewed data that the very small amount of safe supply that is actually used to replace the toxic street drugs that are unregulated, manufactured, marketed, and sold by organized crime, that the safer supply replaces those toxic drugs and reduces the risk of toxic overdose deaths. So we have heard multitude of reports. We hear that Toronto is the chief coroner, and I believe the chief medical health officer actually of Toronto is asking for the government to consider decriminalization. We've heard from the Police Chiefs Association repeatedly, Mr. Chair, about the fact that there's no going back in terms of criminalizing people, that those days are gone. A quote from the chief, the president of the Chiefs of British Columbia Chiefs of Police, and that they were looking for tools in British Columbia to move people out of public spaces so that they could make sure that the public felt safe. And at the same time, Mr. Speaker, they were clear that they want to see more safe consumption sites. And Mr. Chair, I'm disappointed that we won't be in Lethbridge, because Lethbridge is where they closed a safe consumption site. And Lethbridge is ground zero in terms of Alberta. It has the highest death rate in the province of Alberta, 3 times the toxic drug deaths of what we're seeing in British Columbia. Medicine Hat, 63 deaths per 100,000, Mr. Chair. That is almost 40% greater than the death rate of what we're seeing in British Columbia, and almost as much as the highest death toll that we've seen in any health authority in British Columbia. So I just wanted to highlight these really important reasons why we do need to have more meetings. I do support 2 more meetings. I hope that we can center one of those meetings purely on getting an Indigenous perspective. I think that we should invite Ms. Hopkins back out of respect, that this meeting might be cut short and her testimony may be cut short and minimized, and I would hate to see that happen, especially when we know that Indigenous people are, in my home province, are 7 times more likely to die from a toxic drug overdose. In her community, it was 36 times, Mr. Chair. And we also heard from Petra from Moms Stop the Harm, when Ms. Schultz, when she testified, that the recovery model in Alberta is just a name. That that a nation south of Lethbridge, where they were promised a therapeutic treatment center, the only shovel that's gone in the ground is a ceremonial one, 3 years ago. And people are waiting. They're waiting up to 6 months to get help in certain parts of Alberta, Mr. Chair, and that's if they want help. But the goal should be to keep people alive. Harm reduction and treatment and recovery go hand in hand. We don't need to have one without the other. This is a crisis that is ravaging North America, and it is skyrocketing in conservative provinces and Republican states. And we need to change direction. We need to work collectively. And I'll say this, Mr. Chair, that in Portugal, the politicians, where they were successful, is they got out of the way and they let the experts lead with evidence-based policy, evidence-generated policy, peer-reviewed research. That's how they moved forward. And I don't think of another health issue where politicians are having their say like this and interfering with what is truly a health issue. And so that's I support going to 2 meetings, Mr. Chair. And I also wanted to make sure that my comments are on record.
There, thank you, Mr. Johns. Dr. Pawlowski, please.
I would dearly like to get back to the expert witnesses we've invited here and not listen to other MPs wax on about their views on this subject. I was certainly tempted to put a motion to adjourn debate, but I won't. But I would suggest, please, can we not all decide to vote on this? There seems to be unanimity. Let's vote and let's get back to the witnesses. We are doing a study on this subject. We invited these people here to ask their opinion, and I'd like to get their opinions. Thanks.
Dr. Pawlowski, Monsieur Thériault, s'il vous plaît.
Oui, Monsieur le Président.
Thank you, Mr. Chair. I was going to say that I found it ironic that we could table a motion to have more meetings to hear from witnesses when we are not hearing from our witnesses today and we had many questions to ask them. I stated that I would be ready to prolong this study, and I'm not going to take too much time for my comments here. I don't want to contradict my opening statement, but I think that we want to end up with recommendations that will have an impact. We're going out to see what's happening in the field, and if we find out that we need 4 meetings, we can take 4 meetings. But now I'd like to hear from our witnesses, because this is more than one motion that we've adjourned. If we need a subcommittee meeting, I would prefer that we do that instead of showing off how much we understand before the witnesses. I think that it's a matter of respect. I'm open to all proposals, but when we have witnesses, let's ask them questions. And I would like to hear from the witnesses after, and I would like to hear what they think about what's happening in Vancouver and BC and criminalization. Thank you, Mr. Thériault.
No further speakers on the list, so I presume then that we are ready for the question. So the question is on the amendment. And so just to be specific, the amendment is to delete all of the words in the motion, or to delete the following words from the motion. That the committee invites the Minister of Mental Health and Addictions and Associate Minister of Health before the committee for no less than 2 hours, and also to change the word 6 to 2. So the impact of the amendment would be that would be the following: that the study of the opioid epidemic and toxic drug crisis in Canada be extended by 2 meetings to invite further witnesses. Does everyone understand the question? So all those in favor of the amendment, raise your hand. It's unanimous. The amendment is adopted. Now we're on to the main motion. Any discussion on the main motion? Seeing none, all those in favor of the motion as amended, raise your hands. Opposed? The motion is adopted unanimously. Thank you, everyone. That brings us back to the witnesses. And Ms. Goodrich, you have 47 seconds left in your turn.
Thank you for that, Mr. Chair. So really quickly, sorry, I'm forgetting your name, Dr. Polly. More people are dying in British Columbia despite both safe supply and decriminalization. Why do you think that is?
They're dying because 85% of deaths are caused by a toxic, unregulated drug market, and we haven't adequately scaled up interventions like harm reduction and treatment, because it's a combination of those that will reverse the trend.
Do you believe recovery from addiction is possible?
I believe recovery is absolutely possible, and recovery is an individual journey. There are many pathways to recovery.
Thank you, Ms. Goodrich. Dr. Pawlowski, please, for 5 minutes.
Dr. Pauly, sorry for putting you on the spot here, but help the committee out, because you've said in response to Dr. Thériault, who said that the experts seem to come to different opinions as to the evidence for safe supply, and you said, well, you did a peer review and seemed to pretty overwhelmingly show the benefits of safe supply. But let me just point out what else other committees heard. So we asked Health Canada to come and appear before the committee to begin with, and we had the experts that I think were the ones behind approving BC's request and seemed to be in favor of safe supply. they themselves admitted that there wasn't very good evidence for the benefits of safe supply. I would note the BC health officer in a review of prescribed safer supply says, and I'm quoting, most of the limited publisher peer-reviewed studies lack a control of comparison group, and the actual intervention received by study participants is in most cases a combination of broader access to wraparound health services, including safe supply, primary care, making it difficult to attribute any benefit to PSS alone. They suggest that they need to have more studies. The Stanford Lancet Commission that looked at the opioid crisis, and I would point out these aren't a bunch of right-wing fanatics. They, and here I'm quoting from the actual study, they said...
Dr. Pelosi, could you drop the arm of your microphone down closer to your mouth there? Yeah.
How's that? Is that
Thank
better?
You.
So again, I'm quoting from the Stanford Lancet study. They say, and I'm quoting, evidence clearly shows the folly of assuming that population health inherently improves when healthcare systems provide as many opioids as possible with as few possible regulatory constraints as possible. They too were against safe supply. We talked to the head of that, and he said, well, the problem with safe supply is basically you're replicating what caused the problem to begin with, which was us doctors prescribing too many narcotics. People get on narcotics, and then they have trouble getting off of it. So do you continue, though, to say, no, the evidence is clear that the safe supply is good? So.
Yeah, I really appreciate that question about the science, because it has been very confusing and disturbing to see the way that some of the debates have played out. And I'll just begin with the fact that in 2020, many of the citations that you provided preceded or were in the very early days of the development of the body of evidence on safer supply. In fact, since 2020, it's like doubled. And in fact, some of the strongest evidence has emerged in about the last 6 to 12 months. And, our team obviously is in the forefront of producing evidence in British Columbia, where we are seeing positive impacts. So, yes, I stand by my statement in the review of over 40 studies. The findings were overwhelmingly positive. And what I really want to urge this committee is to separate ideology from evidence. And recognize, I don't think there's any of my colleagues who wouldn't say we need more treatment as well. And yet, we know there are still challenges with treatment. People, they come out of treatment and they do relapse as well. So we need to look at what kind of comprehensive system we're creating instead of creating, these ongoing kinds of tensions. And I'll just stop there in case you have a follow-up.
Thank you. And while I would just continue to say that BC Health Officer's report is quite recent, as is Health Canada, and certainly looking at the evidence, I certainly wasn't overwhelmed with it, but let's change the subject. Now, with your study, it wasn't a randomized control trial, right, which is the gold standard. And certainly the validity of your results, I think, depends on how well you matched the people getting safe supply and those who weren't getting safe supply. One of my concerns with your study, and you can correct me if I'm wrong, the comparison group, the people who weren't in safe supply, you got those names from various places, one of them being the discharge abstract database, which in my understanding is from hospital records on people who'd been admitted with either a diagnosis, something to do with using opioids, right? Certainly my concern would be, well, you have a whole bunch in your comparison group, you have a sicker population than you do because they've been in the hospital
Dr. Pelosi,
recently, either because they overdosed.
You're out of time. If you could just get to a question, we get a short answer.
Well, I guess she's heard my question, and I guess I get no response to her answer. But am I wrong?
As succinctly as possible, Doctor.
Answer? Okay, thank you. So in terms of our study, it came out after the provincial health officer's report, as did a number of other studies. The control group, there are multiple linked databases which were used to generate through two different methods. The control group matching on multiple different variables. And I'd be happy to refer you to Dr. Baudin's seminar, which explains this extremely well in terms of how the matching occurred and the similarity between the two groups. So thank you.
Thank you, Dr. Pauly. Suite, M. Thériault, pour 2 minutes et demie, s'il vous plaît.
Oui.
You have 2.5 minutes. We heard from Dr. Morin, who stated that addictions are chronic illnesses, multifaceted chronic illnesses, and so one needs to act at different levels, and relapsing is part of the process. BC would like to make some adjustments. Ms. Hopkins, and if I have time, Ms. Pauly. Ms. Hopkins, how do you see the situation in BC and the government's will to readjust their request? Does this need to lead to recriminalization?
Absolutely not. Thank you for the question. The Expert Task Force on Substance Use and Mental Health recommended safer supply, decriminalization, but they also said within a full spectrum of supports for people who use drugs or substances or who wish to enter into a recovery journey. The task force clearly recommended a more comprehensive and responsive system. So when you provide people with the medication they need to live life every single day, but they don't have a home, they don't have income security, food security, they don't have people that they can rely on to support them, like every person needs another person to support them and be a champion for their belief in their ability to succeed in life, whatever that means. From their perspective, those comprehensive supports absolutely are necessary. In addition, like I said, there's no silver bullet. There's many instruments that will support change, will keep people alive. And safer supply, decriminalization is not a silver bullet. It's not meant to end the opioid crisis and the toxic drug supply, but it will keep people alive. It will ensure human beings have the right to live life. And that should be our goal, is to make sure that human beings can continue to live life. There's many tools. There has to be many tools. This is not an easy answer. It's not an easy solution. But what we're seeing is the focus on one technique, one answer, and criticizing that without considering what are the other resources that are necessary. When those other resources are in place, we've seen positive change that has impacted families, their children, and communities to increase safety, to decrease the number of kids in child welfare, to increase the number of kids going to school, to increase safety in the community. I can't stress enough, a comprehensive approach is necessary.
Thank you, Dr. Hopkins. Mr. Johns, please, for 2.5 minutes.
Yeah, Dr. Pauly, you talked about the effectiveness of safer supply. You cited some really important information. Can you talk also about why safer supply hasn't been scaled up? What are the barriers that you're seeing?
Yeah, this is a really important question, and part of the barrier, without a doubt, is some of the politicizing and the blaming of safer supply for what is a problem of a toxic and unregulated drug market. Safer supply is part of a comprehensive solution, and some of the challenges related to increasing access.
Excuse me, Dr.
Yeah?
Pauly, we're having a problem hearing you here.
Oh, I'm sorry. Is that any better?
Do you want to try plugging and unplugging your headset?
Is that any better?
Yep. Please go ahead.
Okay. Okay, so what I was saying was that part of the reason that Safer Supply hasn't been scaled up is it's been highly politicized, and that's a harmful narrative when the real problem is a toxic and unregulated drug supply. So in terms of scaling it up, we've had quite a lot of insights from the research that we've done around prescribers, and particularly prescribers not being attacked by, feeling criticized by their colleagues, but rather recognizing the importance of the intervention, support of regulatory colleges. One interesting finding we had is that nurse practitioners were 3 times more likely to prescribe Safer Supply. And so in that finding, there are opportunities for removing barriers, particularly in rural and remote communities. And I'd also mention that in British Columbia, First Nations Health Authority has a virtual substance use and addiction program, which was found to facilitate access again for people in rural and remote communities. We haven't talked much about non-prescriber based models, but I wanted to highlight that in British Columbia, only a portion of the people who have died of overdose actually had an opioid or substance use disorder. And we have to remember that we need to consider alternatives that provide access that are appropriate and well regulated for people who are accessing the toxic drug market who don't necessarily meet that criteria.
Thank you, Dr. Pauly. Thank you, Mr. Johns. Next, back to Dr. Ellis for 5 minutes.
Well, thank you very much, Chair. And I know it's been a bit of an up and down meeting for the witnesses, and I appreciate your patience with all of us here. That being said, Dr. Koivu, I'd like to go back to the concept of safe supply, and maybe for the benefit of Canadians out there, you could talk a bit about the specific difference between opioid agonist therapy and safe supply. And of course, we know that opioid agonist therapy has significant amounts of scientific literature supporting it. So if you could explain the difference, I think that would be important to Canadians, Dr. Koivu. Thank you.
Question. Opioid agonist therapy really is about having people on a treatment that can then stabilize them neurochemically, can have them not chasing what we talked about earlier with the withdrawal, and really allow for recovery. The 2 main types of opioid agonist therapy would be methadone, which has been around for years. Next is buprenorphine, and buprenorphine was not available at the time when the study in London was first started. Buprenorphine is a chemical that it's an opioid. It's how it works. As you increase the dose, you don't get an increase in effect, a negative effect. So it is the most proven to decrease the risk of overdose. So when people are on it, they have a decreased risk of overdose when they're from taking it, as well as from taking other substances. Buprenorphine now comes as in a daily sublingual formulation. It also comes in an injectable formulation, which is usually referred to as Sublocade, which is given every 4 weeks. this is a game changer because it really allows people to get their lives back, get back to really the community not having to worry about accessing a pharmacy daily is certainly helpful in remote communities as well, and it provides that healing of the brain to allow people to have a recovery and to function normally. Safer supply programs are about continuing to give opioids at doses that aren't witnessed. And I think it's important to recognize when people are started on both methadone and Suboxone, we check what they're able to take. We understand their tolerance. We work up with them as we're witnessing what they're taking, and we really know what they're taking. When people are started on safe supply, that is not the case. And I'm going to be a little bit more specific about my own community. The doses can continue to go up without reflection for whether that's a safe dose for that person or a safe dose for the community. They're generally given to them on a daily basis. Sometimes it's every few days. But the doses are escalated. In my community, generally, it's at request without any evidence that that's what they need. And even when there is evidence that they don't tolerate those doses, they aren't necessarily decreased. So it's something where people will continue to have to go to a pharmacy. They'll continue to have to go to a pharmacy, usually on a daily basis. It does mean that they're continuing to, from a neurochemical perspective, chase that withdrawal. So it is about continuing somebody in an addiction. They're maintaining their addiction. They're being maintained in a state where they are addicted to the medication.
Thank you very much. Thank you very much for that, Dr. Koivu. And a final question through you, Chair. I'm not sure if you know the answer to this, Dr. Koivu, or not, but our understanding from other testimony is the street price of Dilaudid 8 milligrams has dropped significantly, which is certainly evidence, perhaps not scientific, but evidence of diversion. Is that your experience in your community as well? And maybe you could talk about the price?
Absolutely. It's a market-driven economy. And as there has been more diversion, more available, when in 2016, my understanding from patients and from living in the area is that a D8 was about $20. If you're close to the supply, so close to where more diversion takes place or the core of London, then it varies, but it's usually about $1 to $2. As you get farther away, it's more expensive. So it really is about supply and demand. And as the supply has gone up, so as there's more and more Dilaudid available in London, and from the amount of tolerance people have compared to what they're prescribed, and certainly the amount I'm hearing about, the numbers are certainly over 1 million D8s in a year. But as that number has gone up, the price has definitely gone down.
Okay. Thank you, Dr. Koivu. Et la dernière députée a posé.
And last question for Ms. Brière for the last 5 minutes.
Dr. Hopkins, I have one question for you. What does support the voice of people who use drugs mean to you?
For many people who are experts in their field, have the expertise and the science behind their expertise. They've published, they know their work very well. We rely on them often for the evidence to make informed decisions. We don't typically understand or give credit to the experience of living life every day with these types of conditions that we're talking about, living with dependency to opioids, having to survive the processes of coming to the right dosage for them, how they feel about that. Every person's human being, their physical being, is different from the other. And so the type of medication needed, the amount of medication that is needed to address the issues of dependency, the neurotransmitters that are significantly changed because of the types of drugs that are being used are all in the story of lived and living experience. And it's a credible source of evidence. If you listen to people who use drugs, you will find similarities. Whether you're talking to somebody in downtown Vancouver East Side or a First Nations community in Northern Ontario, they've never met each other, but they will describe the same experiences of withdrawal. They'll talk about their tolerance for incremental increases to their addictions medicine. That's credible evidence. And listening to their voices means that we give credit to people not because of their status in life, because they're using life, because we're judging them or discriminating against them. We're listening to them because they can tell us a real story that is mimicked across the country. That's important evidence. And listening to those voices are just as important, if not more substantial, to the decisions that need to be made about the healthcare system and the wraparound services that are provided to a population of people to ensure they can continue living life without the mental anguish, the physical anguish that goes with withdrawals. People don't wake up every morning wanting to die. They get to those hopeless stages when we have opinions that form decisions, when we make decisions without looking at all of the variables that impact on something like we are talking about safer supply, the toxic drug crisis. We can look at any one perspective and take that one perspective and say, that's credible evidence, and it may be so, but if we don't look at that in the context of the determinants of health, for example, for how people learn to survive every day, then we're short-sighted and we end up making decisions as though we're God. Not one of us have the right to decide who gets to live and who is expendable and who should die.
Merci beaucoup. Alors, est-ce que, puisque vous dites là, que chaque...
You're saying that everyone is different and they all have, and everyone has their own path. Do you believe that a more holistic approach with 4 pillars is the right approach to counter this overdose issue?
Absolutely. We need every tool, every strategy that is instrumental for ensuring life. Not one individual can live on this earth all by themselves. We live in relationship to others. We live in relationship to the land and the environment. We have to consider those elements and those 4 pillars. We now have a substance use strategy in Canada that includes harm reduction. Now we have to figure out what that means. We have to ensure harm reduction, not only for individuals, but we have to ensure we make decisions and policies and resources and programs that reduce the harms to families and communities. And that does not mean erasing the right to medicine, the right to mental wellness, the right to live, the right to that sacred breath of life. We have to provide and look at and life in a holistic perspective. And we can't afford to say, well, you as a population, you don't have the right to life. Or you as a population, because you use drugs, you don't have the right to health. The UN Declaration on the World Drug Problem, which Canada supported, that outcome declaration was that instead of a war on people, we need to ensure the right to prevention, to treat, treatment. And unfortunately, we couldn't get harm reduction in the declaration at that point. But now, this year, the UN Commission on Narcotic Drugs we have a vote that passed harm reduction in international drug treaties. And it matches what Canada has said, and we have to invest.
Thank you, Dr. Hopkins, and also Dr. Pauly and Dr. Koivu. When we invited you, we told you that we would have you out by 5:30. You've been very generous and patient with your time, and very thoughtful in your presentations, and our study will be better because of your contribution. So thank you so much for being with us here today. Is it the will of the committee to adjourn the meeting? I see consensus. Meeting's adjourned.